Good morning, everybody.
Good morning.
Nice to see you. So this is our last session of this academic year. You've all done a great job. This lecture is not in a particular chapter. It's sort of a subretinal, intra-retinal fluid. It was initially subretinal fluid. And I just wanted to talk to you about some different findings, especially some of you launching out into the world. So you think about fluid in the retina in a kind of systematic way. I saw a patient last week from Tom, remember Tom Moore? Tom, you know,
Yeah.
Tom Moore is a great guy. Anyway, he had a patient with a bunch of fluid in the retina, and some person in his area, a general ophthalmologist, was treating with intravitreal injections. And I guess the patient's friends of Tom and the treating doctor, and he said he had him on speakerphone, and he's saying, how can you do these treatments when you don't even have a diagnosis? I said, he said that on speakerphone. It's really funny. So anyway, I think it's important to have a diagnosis before you start treating. So everybody has OCTs now, most of the optometrists in our area have OCTs, and fluid's easy to find on an OCT. It's a dark area under the retina or in the retina. And what I want you to get in your head is fluid, which you know, but just keep it in your head when you get older, is fluid's not always macular degeneration. And what happens now is there's a lot of doctors out there administer anti-VEGFs, and anti-VEGFs work for a lot of diseases. So you can actually, and they're safe. So you're doing something safe and mostly effective, but often without a diagnosis. So so it's not everybody, but there's a fair number of people out there being treated inappropriately. This is the numbers I got off the internet. So if you look at anti-VEGF treatments over the last decade or two, they're just going up, up, up. So the projection for 2025 for the US is about 10 million shots in the country. The estimates from a while ago are about 85% are given by retina specialists. So there's about 15% given by non-retina specialists, which is okay, as long as you know what you're treating. And so that's about whatever that is, 1.5 million in the US are given, right, non-retina specialists. There's a lot of people. In our area, there's a number of non-retinal specialists treating with anti-VEGFs. So when you think about fluid, and this goes back to, you guys probably know this better than I do, there's a fluid balance in the body. So everything in your body has fluid leaking in and fluid going out. We grew from fish, so we evolved from the water. So our bodies are constantly in fluid balance. So the subretinal space has where between the photoreceptors and the RP is supposed to be devoid of fluid, and the RP pump pushes stuff out, and it's also the barrier. So a lot of diseases where there's fluid in the retina, it's the RPE's fault. But there's also fluid in the retina. So intracellular fluid has to do with either damage to the retina capillaries, abnormal blood vessels in the retina, which aren't supposed to be there, lacking tight jumps. And the other thing, which is new, relatively new, I don't know if you know much about, is the Müller cells have a fluid transport. So the Müller cells pull fluid out of your retina through this aquaporin channel, and they pull it either into the subretinal space, so the RP gets rid of it, or they pull the fluid into the vitreous. So any of those systems can go out of whack and you can get fluid in the retina. But fluid has to come from somewhere. So it either comes from the vitreous, so there's got to be fluid that gets in there from somewhere. Vitreous, retinal vessels, optic nerve can leak fluid into the retina, choroidal disorders, or your CSF. So there's fluid from somewhere, or there can be poor resorption. So it can be normal fluid, it's just not resorbing. And that's either from your RP malfunction or the Müller cell function. So this is sort of like when you look at fluid in the retina, you think like, where could this come from? There's something wrong here. This leads to a gigantic list, over the course of the lecture, which isn't too bad. But basically, when you see fluid, it can be any of these. And so I'm going to kind of go through a number of cases which cover most of these and show sort of hopefully something interesting that you weren't thinking about. So this one shouldn't be too hard. 71-year-old man, gradual vision loss over 4 to 6 weeks, difficult transitioning from light to dark to light, and this is the OCT. So when you see this, you shouldn't be thinking macular degeneration. So it's a retinal detachment. And with retinal detachments, the fluid looks corrugated. But what you might not realize how common it is to have subretinal fluid post-retinal detachment repair. It's super common. So if you look at, this is the same patient, I did pneumatic retinopexy, the retina attached, but his fluid didn't absorb from under the retina until 18 months. So it's very common to get this little pocket of subretinal fluid that lasts for a very long time. And it's not visually significant. It's been studied. You don't need to do anything about it, but it's there. But I think it shows that fluid under the retina, even in the absence of anything going wrong, can stay there a while. I think that so this person doesn't have a blood-retinal barrier problem, doesn't have a vascular malformation. They just have fluid that built up there, and now it's just taking forever to go away. So when we treat fluid under the retina, even when your treatments are effective, it can still be there for a long time. And that's why I think when we treat diabetics, the standard for most of our patients, when we think about it, is macular degeneration goes away pretty quickly, but diabetic retinopathy usually takes 5 to 6 months to respond. And patients ask me a lot of times how quickly they might get better. I think a reasonable answer, and I've never seen it, this would be hard to study, is about how long it's been bad. So if someone's been getting bad for about 3 months, it's probably gonna take about 3 months to get better. If someone's been bad for a week, it might take a week to get better. And I think that's because the fluid concentrates.
How long was he back off for that he?
Just a week or two. And these can be MAC on. Oh, anyway, so this is a study that was done. So persistent subfoveal fluid following MAC off and MAC on retinal detachment repair. In 1 month, there's 94%, 3 months, 72% eyes, 6 months, 55, and actually in a year, over 10% of eyes have subfoveal fluid. I have to say, these numbers seem a little high. When I look at my patients, I don't think it's this high, because I checked for this. But it's a remarkable number of patients actually have it. It's not a rare thing. So vitreous. So one source of fluid is vitreous. Another source of fluid is retinal vascular disease, and this is a bunch of things. So anything that disrupts your blood-retinal barrier, it can be inflammation, like uveitis, traction, macular puckers can disrupt the fluid, infections like syphilis, which we see all the time, infiltrations, neoplasia, and vascular. So retinal vascular disease is a million things that cause subretinal fluid. You all should know the inner blood-retinal barrier is the tight junctions between the capillary and endothelial cells, but there's also other things that parasites contribute. That's why diabetics, get a little leaky, and also something else in there, microglia in the Müller cells. The Müller cells actually support the blood-retinal barrier. That's why probably in MacTel, which is a Müller cell disease, probably they get those leakages probably based on the Müller cells like that. So this is the 82-year-old guy with cataract surgery. This is his OCT. It's not hard. But the interesting thing about this OCT is there's subretinal fluid and intraretinal fluid. Fluorescein shows leakage in the macula and leakage on the nerve and sort of leakage everywhere, early, late. And so this is just pseudophakic macular edema. And then this is a branch vein occlusion span there. And what I wanted you to get from this is branch vein. Intraretinal fluid can become subretinal, and it probably is a sign of chronicity. So it probably has to do with when you get a CME or branch vein occlusion that's relatively fresh, you don't get subretinal fluid, but it's been there a while, the subretinal fluid builds up. And it's probably the last line there, the disruption of the external immune membrane. There's these zones, it's not a blood retinal barrier, it's not a tight junction, but it is a junction, the zonular adherence rather than zonular occlusions, I think. And the zonular adherence of the external membrane probably break down in these cases and get the subretinal fluid. And these can look, a little bit like macular degeneration. I've had patients with macular degeneration who have these macroaneurysms that pop up because it tends to be an older population female, and you're treating them, and it's like funny, they're getting worse and not better, and then you let them be like, oh, macroaneurysm. You got to look around. I had a patient referred from somebody I consider to be a pretty good retina specialist who was a spouse of a patient of mine who they said, why don't you let Dr. Cohen do the testing? It might be central serous. And it was actually, blood the case eventually. It was subfoveal fluid from a melanoma, So
Look around.
You gotta look and see the melanoma, which, and it was in that weird zone. We talk about that zone where you look in the periphery, you look in the macula, and there's stuff in between sometimes that you don't see. This is the optic nerve edema can cause intraretinal fluid, not uncommonly. There's these glial cells of KUHNT, it's hard to pronounce, intermediate tissue, which cause tight junctions and zonular occludens. And the retinal pigment epithelial cells form a zonular adherence, and in that area, sometimes fluid sneaks through. That's a weird anatomy. I think you do need to know that. So optic nerve edema is a bunch of causes, either fluid from, you get blood, axoplasmic interstitial, axoplasmic flow stasis from, intracranial fluid problems, intracranial pressure problems, peripapillary subretinal fluid is common, and then fluid can come from the choroid or the peripapillary capillaries. This is a long history. This was a patient who had vision loss for a couple of days, cobwebs in their vision, smoky vision. They saw black lines. They had gotten a cat recently that was 6 months old, and they from a kitten from a litter, and the vision's 21, 25, and the nerves all swollen up. And this was actually neuroretinitis. And you can see the fluid under the retina, but you can get fluid with ischemic optic neuropathy. So even ischemic optic neuropathy, about 10% of patients have subfoveal fluid in 4 weeks of symptoms. So you can get fluid from that, which when you see it, it's a little weird. So that's vitreous and retinal vascular and optic nerve disorders. Choroidal disorders is a common cause of subfoveal fluid. And that again is a long list. So your retinal vascular and your choroidal list is very long. And this is what we do like for years and years and years in conference. Inflammatory, infectious, infiltrative, neoplastic, vascular, and medicine induced is a new thing. And this is a bit busy slide. So in inflammation, you've got VKH and sympathetic, which we never see in posterior scleritis, infection. You know, there's some funny ones. I haven't seen a unilateral acute idiopathic maculopathy in a while, but that's a Coxsackie virus. Tuberculosis, syphilis, which we see, benign and malignant tumors, neovascular membrane. It's a vascular insult like hypertensive, fluid imbalance with a pachychoroid, which is this whole bundle of things now, which is probably mostly central serous. But I did see a patient recently with what we used to call transplant retinopathy from steroid therapy or transplant. It's probably steroid related, but sometimes a person with transplants get hit with so much junk and their body's out of whack and the retina just floats off from all the fluid. And then all the new medicines. You got the MEK inhibitors, the checkpoint inhibitors that can cause, either mess up the blood-retinal barrier or cause inflammation. So there's a lot of things you can do for it. And the outer blood-retinal barrier, you have to know, is the RPE, a tight junction in the RPE cells is your outer blood-retinal barrier. It's not Brooks membrane. Okay, so if anybody, that's got to be on a million tests. And that can be disrupted. So this is a patient where it's not disrupted. So this is a patient I haven't seen forever. He still comes in with Sturge Weber. He's my one Sturge Weber patient. He doesn't mind his picture being taken. So I have him in all the lecture books. But he is Sturge Weber, so he's got a choroidal angioma, but there's no subretinal fluid because the blood-retinal barrier is intact. But this is another patient. So this is another 13-year-old kid who got hit with a softball and then had no vision loss, but then his vision got blurry, and he comes in with this lesion. And anyone know what this one is? We haven't seen this in conference, I think.
It was right after, how long after you got here?
He got hit with the softball a couple of years ago. It's got a certain appearance to it.
I know the appearance you wanted to say, but I don't know the diagnosis.
It's osteoma. So a kid like that, so they get that funny looking, the RP, stippled RP, like a leopard spot appearance, and then the fluid in a kid. And this is the FAICG. I haven't seen osteoma in a while. And then the ultrasound shows that reflection of the back. It's not super bright. They're not always super calcified. It's not like totally shadowed, but it's pretty bright. So your choroidal masses, you got amoebases, which are 5% to 7% of people, osteomas, who knows. Choroidal melanomas are 6 per million, and metastases are 60 per million. It's interesting when you look at these numbers because Tampa Bay is 3 million people. So that means probably every other day someone's got a choroidal metastasis because 180 people per 3 million. So these things are not super rare. But anyway, so choroidal masses,
I thought about that, the problem is they got so much else going on at that point.
Yeah,
That hell, who cares,
And I always think about the RP, I always think about the statistics for like dystrophies, and I think a lot of them just don't come in. They just don't like going to the doctor, it's so irritating. This was a patient who was sent in for me for sort of a funny, this is a 36-year-old female, this was a while ago. Had treated for 6 years. Avastin, Ozurdex, PDT, micropulse laser, diagnosed with macular degeneration. There was concern at one point. I'll show you the picture. This picture made the treating doctor worry about a possible parasite. So they said they thought it might be. They got an autofluorescence and they said, "Oh, that might be Dusen or something," which is. And so anyway, but at least he sent the patient over because so there's this big brown spot in the center of the macula. Which is, when I was in Miami, I was at Baskin for a couple of years, and they did a weekly fluorescent conference. And one of the only cases I saw that stumped the room was a subfoveal nevus. It was just so funny, because you look at the macula and you think, is this syphilis? Is this like one of the, big comatoses or whatever? And it's just a nevus in the middle of the macula. So this is just a subfoveal. And the autofluorescence is a little funny looking. But then on the OCT, you can see a nevus, and you'll get used to these OCTs, so that absence of vessels under the macula is kind of where the nevus is. And then what it has, it's got a little neovascular membrane on top. So it's not uncommon for nevi to get little neovascular membranes on top. I've seen a couple of these, and they respond really well to PDTs. So about 25% of subfoveal nevi lose vision. Fluid sources can be just leakage, but it often is a neovascular membrane. And fluid over nevus is worrisome about transformation. This is Dr. Shields' paper. So anyway, so it's nice to have your diagnosis, micropulse laser. So
what were those nasal lesions on that?
oh, those would have just been what were they?
Laser spots.
They might be laser spots. No, why would you laser out there though?
Who the hell knows?
They do look like laser spots a little bit though. I mean, they look kind of like pattern dystrophy, but not really in the macula. So I mean, they're hyper, there's a lot of lipofuscin there. So that would be probably, drusen stuff. Yeah, it's interesting. Yeah, I kind of went past that because they're not clinically significant. It looks a little bit like serpiginous, but yeah, but it's, just excess lipofuscin or something. Thanks for asking. Serous retinal detachment. This 71-year-old patient, no visual complaints. So this is a patient asymmetric. So the right eye is normal, the left eye has this funny looking, pigment thing. You get the OCT, there's fluid under the retina, and then there's a step off. So that's a staphyloma going back there. So that's a staphyloma you're seeing in the left eye. And then there's this fluid under the retina. The pictures don't show much. Your FA and your ICG are kind of equivocal. So we had a case like this earlier. So this is sort of the dome-shaped macula posterior staphyloma fluid thing. But the thought is it might be abrupt transition in choroidal thickness, and that causes subretinal fluid, or maybe the vessels are a little funny. There's something about the choroidal vascular pattern in these patients. It's a little different. It might be something with the sclera. It could be choroidal. People just don't know. But basically, they have a good visual prognosis. And this was a case from a while ago, 2017, which is now 6 years ago, no, 8 years ago. Yes, about 8 years ago. Over time, people are starting to realize that these dome-shaped macula staphyloma patients just should be left alone. That basically the fluid can come and go, but Kim presented the case. The fluid can come and go, but basically what you do doesn't really matter. And the case that we had that Kim presented, we did everything and then stopped. And actually, it was weird. As soon as we stopped, the fluid went away, and those patients only. And then the last thing I want to talk about was CSF fluid, or one of the last things. So you can get fluid from the CSF, an optic nerve pit problem. So it can be congenital, imperfect closure of the optic nerve. It's about 1 in 10,000 people, and it can be in children or adults. And the EGI over the optic nerve can sometimes find the pit, and you have to rule out other diagnoses. And these can also be acquired. So they're seen sometimes in glaucoma patients. So you can get acquired pits in older patients. This is a 10-year-old. I like these cases because they did so well. We saw these both together, and this was a while. David Eichenbaum and I saw these cases. So it's a 10-year-old with vision loss. We followed for about 6 months. The fluid didn't go away. My patient, I think I did the laser just because I felt I should. I don't think the laser does anything. This was the fluid. That does look better. And then, you know what happened? Okay. And then the other one was David's, I think. So we had 2 cases. Anyway, but what it was, this is a video. I put these in the wrong order. So these were cases that David and I did. Hopefully the sound will play. Surgery back to back. So this is somebody with this is one of the kids with an optic nerve pit, and you can sort of see the fluid coming out. And this is that optic nerve fenestration we were talking about. So basically you do nothing except for take the blade and just rub it like that. You can see the retina wiggling. You're trying not to stick a hole in the retina. So you're just trying to fenestrate the nerve fiber with a 25 gauge needle. And we had to bend the needle so you can see past it. You're trying to look over the needle. And then this was this eye preoperative, and then this was postoperative, and it goes away.
To me.
And then this was, yeah, it's really cool. And then this was the other one. We had two, we did them both the same day. So just a little vitrectomy just to get the vitreous, so you have a path with the needle. We don't create a PVD. And then you do a little stroking thing there. And again, you're trying not to stab it, you're just trying to touch it and scratch it. And the idea is to disrupt the internal membrane. So fluid can go from under the retina into the vitreous, probably through the needle, probably helps the Müller cells a little bit too. And this one got better too. And these patients in both been watched for about 6 to 12 months. And Spade did the paper. So that was supposed to be before this slide. So what he did was he had 17 of 18 eyes had resolution of subretinal fluid, vision improved, and none of them recurred. So there's all these treatment, and this is still not accepted as standard treatment. I don't know why. So you still read papers about people doing like flaps or ILN flaps over the pit or vitrectomies with bubbles. But in a kid, it's such an easy procedure, and it worked for us. And it makes sense. It's kind of logical. He's a very logical guy. This is a patient with vision loss in both eyes, a 77-year-old, saw him a while ago. And basically, this is what his retinas and choroid look like. You can tell these are older, they're older camera. And he's got this choroidal infiltrate and waviness, and then the sort of this stippled autofluorescence in both eyes. And the fluorescein doesn't show that much, the ICG doesn't show that much. So this is a case of beat up. I haven't had one of these lately. So bilateral diffuse uveal melanocytic proliferation, they get subfoveal fluid. And they get cataracts, and it's a paraneoplastic syndrome. Compromised resorption. Oh. Sorry. So this is a 72-year-old guy. Left eye is not as good as the right eye, and he's got gradual vision. So this is the left eye. And you see this, and you guys know what this is, because it's not really, there's something under the retina, but it's not really clear. You know, it's kind of material under the retina. And the autofluorescence looks like that. Do you guys know what that is? Under the retina. We've had it a couple times. So, yeah, it's a it's a vitelliform lesion. So this is we used to call them pseudo-vitelliform lesions, or vitelliform, I think it's fine. So it's a vitelliform lesion. You can get it with macular degeneration, you can get it with pattern dystrophy, you can get it with macular puckers. One of you guys talked about it. Excuse me, this last year. Wasn't it Dubish? Yeah.
You had to do the best.
Yeah, you did the best, but anyway, so vitelliform lesions, you get stuff under the retina, but it can look like fluid. And then what happens to a lot of the vitelliforms is they go through these stages and they end up with atrophy, which is unfortunate. So most of those patients within 5 to 10 years will lose central vision. I shouldn't say that. Most of those patients in their 80s, 70s or 80s. So you'll see them in their 50s. And they often like hangs on until they get older, and then around 70, 80, it sort of gives away and they get the central atrophy. There are stages of vitelliform, 1, 2, 3, 4. This would be a 1 initially, and then when it layers out, it gets a pseudohypopion, it's a 2, and then when it scrambles, it's a 3, and when it atrophies, it's a 4. So when you look at adult vitelliform macular degeneration or adult vitelliform dystrophies, a lot of them do have fluid. My dad, years ago, he had some fluid. It wasn't central in his retina. And we treated him a while, then he went up to Boston. They thought it was just vitelliform fluid. So ultimately we just kind of ditched the treatments. He was kind of moderately demented. He was a little grumpy, so not treating him was nice. And anyway, he did fine. So these adult vitelliforms can have fluid. Oh, and then there's a couple of fun cases. So you can have macular degeneration, because that's the main thing I want you to get in your heads is macular degeneration. Fluid is not always macular degeneration. So this was a patient came in with all these drusen and then this OCT. And she said she'd seen 3 different retina specialists who had told her 3 different things about what she had and that she should be treated or shouldn't be treated. This is kind of a funny one. I think we had this one in conference. Does anybody know what this one is? What that scan could be?
It looks like the ILM draping in Mactel.
Yeah, perfect. Yeah, it's Mactel. So it's a Mactel patient with drusen, which is kind of fun. And then when you get the fluorescein shows, not much. This picture, the multicolor does kind of show a little bit of a ring if you look at it long enough. you know, like kind of a ring. You're supposed to get this blue ring on the blue reflectant. And then do I have another one? No, and then the other thing you look for is the absence of the pigment on autofluorescence. So MacTel can give you some fluid looking, and then these last two cases are, I think these are the last two are important, because what this is this is a patient who's got fluid under the retina and all these drusen. And then the fluorescein really doesn't look like much. I didn't have, this is where OCT angiogram is really helpful, but the fluorescein doesn't show much. ICG doesn't show anything except for the drusen. And you watch it, you don't treat it, and then the fluid just sits there. I saw this lady, I told her she's in my lecture. I've been watching her for, I think, 10 years. And then this is another one. This might have been a lady I just saw yesterday. And there's fluid in both retinas, and there's drusen, there's a macular pucker, the OCT, the ICG shows nothing. OCTA wouldn't show anything either. And you look at it over years and years and years, it's just fluid with drusen. So you can get fluid with drusen, and it's usually that configuration where you have these little domes. And I think there's two good theories. The theory that's mostly out there is that it's a mechanical thing where you can't, like, if you imagine trying to smooth your retina into this little trough, there are these domes. That one especially. So there's drusen or deposits, and the retina just can't go down in between them because it just can't get there because the elasticity or whatever doesn't do it. I don't know about this one though. Sometimes this one looks like it could go down. So I think some of it's just poor absorption. So I think it's a combination of poor absorption and this might be a little pachychoroid too. I don't know. I have to look at these cases, but I don't think pachychoroid's considered in there. So you can get drusen with fluid. So, and there's no harm if someone has macular degeneration, it's equivocal, which it often is. There's no harm watching them for a little while and seeing what it is. And if it is wet, you can treat it. It's very rare. What everybody worries about macular degeneration is a catastrophic event. You know, subretinal hemorrhage, sudden vision loss, you never get the vision back. That's probably 1 in 100 patients with wet. It's very rare to have a catastrophic event. And then this is one, actually is the last one, I think, because I just saw this. This guy's about to leave. I just operated on him recently. So this is an 86-year-old guy who comes here. He had his first injection a month ago with Eylea in New York. He spends his winters in Florida, and he's being treated for fluid in the retina. So it's hard because I see him and I don't know what he looked like before. You know, that's where you get all these patients that are snowbirds. They come down, they're getting treatment. 95% of the time, I just continue what you're doing because, you know, you figure you're seeing him for 2 or 3 months. But this guy, his retina didn't budge. I gave him, and sorry about this, these all are the same. I managed him with Eylea monthly for 3 months. It didn't budge. And it looks to me just like a macular pucker. It doesn't look like macular degeneration. So it looks like macular pucker with some underlying fluid. So I said, you know, I know they were treating you with shots, but I think you just have a macular pucker. So I operated on him about a month ago. And I think this was about 6 weeks ago. And this was his post-op scan. So I peeled the pucker and I also put some Kenalog under the retina. So just under the subtenos Kenalog, I do that with the blocks. And he was perfect afterwards. And I put a gas bubble in because it was a really tight pucker. When it pulled off, the retina like stretched, which I suppose makes me nervous. So anyway, he's totally dry. So I don't think he needed the shots. I think it was, and I don't know, I didn't look up who the doctor was that was treating him, but I think it was just a macular pucker with fluid. It wasn't macular degeneration. So when you see fluid in the retina, it's got to come from somewhere, and it's either building up inappropriately or it's not absorbing. So you either have excess egress, you know, from either the vitreous, the vessels, the optic nerve, the choroid, or the cerebrospinal fluid. And in MacTel, I guess you could say interstitial tissue too, maybe. And then, or you have poor resorption, and it's not always macular degeneration. So that's the summary. So just keep your eye out, keep your head turned on when you get out there and starts, especially if what happens, you get busy, you know, you're in a busy clinic. It works. People come in with problems. The other thing is, I hate to say it pays pretty well. You know, the shots right now, they still pay pretty well. There's all these incentives to, you know, get you to give shots. So anyway, just be careful with that. Any questions about all that? So that's not any particular chapter. I figure we have one more day and I just go over that.